This is Dr. Ihab Abdurrahman Ihab Tarawa, consultant of acute care medicine at Sabah University Hospital, professor of medicine, University of Khartoum. We're still doing our session, basic emergency care, trauma module. This is the second session about sample history and secondary survey. After we do the primary survey, and as we mentioned that in the primary survey, we would like to check the life-threatening condition, then we go for sample history and secondary survey. In sample history, we assess symptom and sign, we assess patient allergy, medication, past medical history, last time he had an oral intake, and then we ask about events surrounding his illness. You want to make sure if there is any change in patient voice like hoarseness or raspy or gargling. Change in voice in association with injury to the head and neck or with burn may suggest airway swelling, and it can progress to complete airway obstruction later on. Also, does the patient have any difficulty in breathing? Problem with breathing may develop over time and may not be obvious during the early ABCD approach, and this is why repeated assessment is needed. Difficulty in breathing could be linked to some injuries to the lung, to the ribs, to the muscles, chest wall, and this can progress to one of those life-threatening conditions like tension pneumothorax or massive hemothorax. To predict the amount of blood loss, first, if there is obvious bleeding, you can estimate that, but also you can ask the patient or those who have been with him about any previous bleeding before arrival and how long had they been bleeding before someone applied any first aid measures, how many bandages have been soaked, and is the bleeding getting better or worse. Patient may have difficult time estimating blood loss, so using length of time, bandages, soaked can give us a clue about how much he lost. We need to assess if there is any confusion, unusual sleepiness, or lethargy. First, think about effect of hypoxia on the brain because it can lead to this. Also, hypoperfusion with significant blood loss or fluid loss. This can happen due to hypoperfusion. If you maintain adequate oxygenation and perfusion, you need to consider this could be related to head injury. Head injury can cause bleeding and increase intracranial pressure, and this can lead to confusion and even coma. In sample history, we will ask about pain. Is there any pain and where is it and how does it look like? Pain will point to the site of injury. Pain in the skull can present as headache. Pain in the chest can reflect something in the lung, and pain in the pelvis could refer to pelvic fracture, and pain in the limb can also refer to some injury in this region. As part of the secondary survey, sign and symptom assessment and analysis, you ask about nausea and vomiting because this could be related to abdominal injury or raised intracranial pressure. If there any numbness or weakness, that could be reflecting spinal injury, and any change in the vision, and this can be related to direct eye injury or head injury. It's important to ask about allergy, what kind of allergy he has, and she should describe it, and what medication, and this should be documented well in the chart in a visible location. When we are prescribing, we would like to make sure not to give a medication to which the patient is allergic. Then you ask about medication, what are the current medication, any new medication or any change in the dose, and also ask when did he take the last dose of each medication. Some medication can affect clotting and worsen the coagulopathy that induced by trauma, like aspirin, clopidogrel, and also use of anticoagulant. Blood pressure medication, especially the long-acting one, could make the management of shock difficult. Assess the past medical history. First, ask especially the ladies on childbearing age if they are pregnant and when was the last menstrual period. Pregnancy can cause some of the organ to move out of their regular position, and pregnancy change the body response to trauma. Patients who are more than 20 weeks should be placed on the left lateral side with C-spine immobilized so that to improve the blood return from the lower limbs. Ask about any other medical condition like diabetes, hypertension, heart or lung disease, liver disease, kidney disease, pregnancy, immunosuppression, or any bleeding disorder, because these conditions need to be managed concomitantly after we stabilize the patient, and some of them increase patient risk for some outcomes. We need to assess when was the last tetanus vaccine, and because those with penetrating wound, and if the tetanus vaccine is more than 5 years, we might need to re-update their vaccination. Then you ask when was the last oral intake, because patient with full stomach might vomiting, especially during induction of anesthesia or if they need intubation for ICU management. Exposure, which is about the events surrounding the illness, we will ask about the mechanism of injury and if it's a motor vehicle accident, was there a seat belt? Is the seat belt was on during this accident? For those who are subjected to assault, what type of weapon? And also we need to know if the patient has been on any drugs that can impair consciousness, benzodiazepine, narcotics, or use of alcohol. For burn, we need to know if it is fire, scalding, or chemical. Some mechanism of injury, it increases the risk, even if the patient appears stable. For those who are ejected from the car, or if there is one passenger who is dead, all this increase the risk of that injury. If there is a fall, is it like from 3 meters or more, or twice the height of the child? A greater distance fall and increase the chance of serious injury. Fall in adults are often associated with old age, alcohol intoxication, or failure of workplace equipment. Fall in children often from trees, windows, or balconies. Regarding events surrounding the illness, for pedestrian and cyclists, if they are hit by a car, and if they were thrown, and how far they were thrown, and if they were wearing a helmet. Pedestrian or cyclists are always at high risk of serious injury. Children may not be able to report the event. Always consider possible unwitnessed trauma in young children. Those who are ejected consider multiple injury. If they are ejected, this can affect the head, the chest, the neck, the abdomen, and pelvis. If the injury is induced by burn, what type of burn, and what if the patient receive any first aid intervention. Flame burn is in an enclosed space, might cause inhalation and airway injury. Scald burn is very common in children. Injury from chemical may appear as injury from electrical burn can appear as small, but it can lead to extensive tissue damage. For chemical injury, it's important to learn if there is decontamination happening, and also the healthcare providers, they need to protect themselves from being exposed. Anyone with burn less than 3 hours is better to wash so that to stop the burning process. For the event, also you ask if the patient sustained a crush injury, is there any pain or numbness, what about the urine, if it is dark or not, and how long was the body part crushed. And also ask about blast injury. Crush injury damages skin, muscles, blood vessels, and bone. Dark urine may signify hemoglobin in the urine, which can reflect rhabdomyolysis. Swelling can build up pressure, limiting blood supply and lead to compartment syndrome. Those with blast injury can involve body system, especially hollow organ. Common site include the lung, intestine, and ear. For blast injury, consider foreign body injury, burn, chemical, toxin, and radiation exposure. We do secondary survey after we finish the primary survey. Usually we implement look, listen, and feel. During the primary survey, we implement the ABCDE approach and we look for life-threatening condition. If there is any critical airway problem or critical breathing problem like tension pneumothorax, hemothorax, flail chest, or sucking wound, or there is shock or suspected cardiac tamponade. After we do this, then we go back to perform head-to-toe examination to uncover any other injuries or missed condition. But during this process, some injury might be cooking. If we notice any abnormality, we have to stop the secondary survey and go back to the primary survey. We start the secondary survey, start from the head. We look at the head, the eye, ear, nose, and throat. Look for any wound in the scalp or bruising, skull deformity. If there is any blood coming from the mouth or blood in the throat, examine the pupil if they are equal and reactive, and they move and the eye movement. Check for the vision if there is any visual loss or eye injury, and any problem with eye movement. Check for blood and fluid in the ear and nose that indicate fracture base of the skull, and also look for tooth injury and poor alignment. And also we have to look for sign of airway burn like ash, sign of nasal hair, or new worsening lip or mouth swelling. Listen if there is any stridor, gargling, or change in voice, and feel for any tenderness or abnormal movement of the facial bone. Look for teeth that could accidentally be inhaled. Detect for any crepitus in the skull or facial bone suggestive of fracture. Examine the neck and look for reduced ability to move the neck or pain on movement. See if there is any bruising, bleeding, or swelling. Hematoma in the neck can increase and lead to airway obstruction. You look at for any penetrating neck wound, and also look for distended neck vessels, which can signify tension pneumothorax or tamponade. Feel for air in the skin or soft tissue that could be part of a pneumothorax. Look also for tenderness and deformity along the spine. Then you move to the chest, see if there is any bruising, deformity, or wound. Look at the chest movement. If there is unequal or uneven chest movement, that could be related to pneumothorax. Look for burn around the entire chest, circumferential burn, which can cause difficulty breathing. You listen for breath sound, especially if they are dull or hyper-resonant. Muffled heart sound can be seen in patients with pericardial tamponade. Feel for any tenderness or crepitus. Then you do secondary survey for the abdomen. Look for any abdominal distension, visible wound, bruising or abrasion, bruising on the back side, which may indicate bleeding into the abdomen. Look for circumferential burn to the abdomen, which can impair breathing. And you have to feel for tenderness and rebound tenderness, and also abdominal tenderness in all quadrants, which may indicate organ or vessel injury. After the abdomen, you do the secondary survey for the pelvis and genitourinary system. Look for bruising or laceration to the pelvis, blood at the penile or at the opening of the penis or vagina, vaginal laceration or bleeding. This might indicate pelvic fracture or injury to the uterus, or source of blood loss or sign of sexual assault. And also you look for benign laceration, periapism, which can indicate spine injury, urine color, which can reflect rhabdomyolysis, especially when it is dark. Feel for tenderness or abnormal movement in the pelvis. For the extremities, look for swelling or bruising, any deformity or open fracture. Some organ could be amputated. Look at them and make sure there is no bleeding at the stump. Circumferential burn can happen, and also pale skin can indicate loss of blood flow. Feel for absent or weak pulse, cold extremities, that can signify shock. Look for tenderness. Abnormally firm, painful muscle compartment, that can indicate compartment syndrome. Then you do secondary survey to the spine. You do log roll, you have to get assistant to do that. Look for bruising or deformity. You need to feel for tenderness, crevitus, and alignment along the entire spine. And presence of tenderness, crevitus, misalignment over other with visible evidence of trauma. If concern for spine injury, check and document the level where the finding starts. Then you move to skin, look for any bruising, abrasion, laceration, or burn, especially circumferential burn on the chest and abdomen, and that can affect breathing, or circumferential burn on the limb that can lead to compartment syndrome. You need to feel for peripheral pulse in all extremities. Neurologically, look for decreased level of consciousness, do AVPU or Glasgow Coma score. Agitation or seizure or convulsion can signify serious head injury. And assess movement and strength of power in each limb. Sensation on the face, chest, abdomen, limb should be assessed. If there is deficit, identify the level it begin. Priapism can reflect spinal injury. Decreased sensation, decreased strength, or priapism consider spine injury. In secondary survey, we would like to implement look, listen, and feel. We do that after we finish the primary survey through the ABCDE approach. We would like to perform head-to-toe examination. Remember that very painful or frightening injury might distract patient from other injury. During secondary survey, we would like to uncover any injury or organ dysfunction that inflicted by trauma and to manage them appropriately. During this process, whenever there is deterioration, we go back to the primary survey through the ABCDE approach, and see you in the next session.